Okay, hi everybody. Welcome to today's webinar series, where we have a very interesting discussion today, and I'll be co-moderating with Dr. Shazia Bhombal. My name is Jack Wren. I'm one of the clinical assistant professors at the University of Iowa. Like I said, I'll be moderating with Shazia. We're both very excited to co-moderate on a topic that I think will have a lot of productive discussion today on acute pulmonary hypertension in the neonate. So it's my privilege to first introduce our speaker, Dr. Faith Zhu, who's a rising star in our field. She's a staff neonatologist at Mount Sinai Hospital in Toronto, and an assistant professor in pediatrics also at the University of Toronto. She completed her medical education at the University of Edinburgh, followed by pediatric residency in London, a neonatal perinatal medicine fellowship at the University of Toronto, and then her advanced fellowship in neonatal hemodynamics and targeted neonatal echocardiography, also at the University of Toronto. And her main areas of academic interest include the use of targeted neonatal echo in critically ill neonates and the long-term cardiopulmonary phenotypes of preterm born children. So after her presentation, we'll have a discussion with a very esteemed group of panelists who are true thought leaders and content experts in this field, and we're very pleased to have them with us today. First, I'll introduce Dr. Neil Patel, who is a consultant neonatologist at the Royal Hospital for Children in Glasgow, a senior NHS Research Scotland Fellow, Scottish Quality and Safety Fellow, and Clinical Innovation Lead for West of Scotland Innovation Hub. He has lots of interest, but a specific research interest in expertise in the hemodynamic and precision care of neonates with congenital diaphragmatic hernia, who obviously have a significant contribution to pulmonary hypertension. Next, we have Dr. Stephen Abman, who's a professor of pediatrics and director of the Pediatric Heart-Lung Center at the University of Colorado, Denver, and Schitt's School of Medicine and Children's Hospital of Colorado. He wears many hats, but of note to this talk, he's the founder and director of the Pediatric Pulmonary Hypertension Network and an expert in research in pathophysiology of neonatal pulmonary vascular disease. And then finally, we're pleased to have Dr. Stephanie Ford, who's a neonatologist and physician scientist with appointments at Rainbow Babies and Children's Hospital in the Division of Neonatology, as well as Pediatric Cardiology, and as well as at the Case Western Reserve University School of Medicine. Her clinical and research interests center on the etiology and treatment of neonatal congenital heart disease, including linking embryonic blood flow to cardiac function. So thank you all of our panelists and all of you in the audience for joining us. I'd remind you, if you have questions, please put them in the Q&A box as opposed to the chat box so we can find them. And after the initial presentation, we'll then open the floor to questions to our panelists. So Dr. Zhu, the floor is yours. We're excited to hear your presentation.
Thank you so much, Jack. I'm just going to share my screen. Let's see. Perfect. Is that all? Can everybody see my screen okay?
It looks good on our end.
Awesome. Thank you. So thank you for the lovely introduction, Jack. My name is Faith. I am one of the staff neonatologists at Sinai, and it's such an honor to speak here on this platform that really it's a great opportunity for learners as well as people who are experts in this field to all come together to discuss these topics that are often very important to us as neonatologists. So to begin with, I have no conflicts of interest to disclose, but of course we'll be talking quite a bit about nitric oxide in preterm infants, and that is an off-label drug use in today's presentation. So what I would like to sort of talk about today is in particular looking at preterm babies and why it is that they are quite unique in how they develop acute pulmonary hypertension. And also looking at what the hemodynamic profile of these babies look like. And then we'll pivot to looking at management of pH, including nitric oxide use, as well as some of the evidence and practice that's currently happening, and then some discussion on the second-line agents. So many of you have probably seen a diagram like this, which describes the PVR and SVR in the fetal life as well as in postnatal life in relation to the gestational age. And as you can see here, PVR tends to fall towards a sort of early 32-week gestation, and that is characterized by the saccular stage of lung development and an increased surface area of of the lung development. And then subsequently, there's an increase in your PVR, which is in response to sort of intrauterine oxygen. And post-birth, with changes in your PVR and SVR. In a normal situation, you see the drop in the PVR and a rise in the SVR, as you expect in a normal postnatal development at term. However, oftentimes you're meeting these preterm babies actually really early on, before even the saccular stage. And you can see here that they actually have a disruption to this development, and which puts them at a particularly unique position where their PVR is at birth already higher than where it's supposed to be. And in terms of pulmonary hypertension, this describes an increased PVR state secondary to a failure of the typical fall that we see in the postnatal adaptation after birth. And what the high PVR state leads to is reduced pulmonary blood flow, a ventilation perfusion mismatch, and then as a result, hypoxic respiratory failure. In particular, in acute PH, hypoxic pulmonary vasoconstriction is a really important mechanism where the lung and the pulmonary vascular bed there's a mismatch in the VQ mismatch at this level. And this leads to a cellular release of calcium in the pulmonary artery vascular smooth muscle cells, and then it precipitates local vasoconstriction, diverting blood away from those poorly ventilated areas. And as a result, you're faced with a hypoxic infant due to this VQ mismatch, and this therefore, you can see there increased local vasoactive mediators, leading to further increase in vascular tone and the pulmonary arterioles and veins in these babies. So that is really one of the key underlying features that we see in hypoxic respiratory failure in pulmonary hypertension. But what is particularly unique as well for preterm babies is that, these are babies who were likely born because of some maternal complications like preeclampsia, infection, PPROM, these sort of settings, which already, even before they're born, are at particularly high risk of not just smaller blood vessels and smaller alveoli, but also abnormal function because of abnormal signaling in these babies. So you can see then, from a structural standpoint, they're smaller, therefore smaller blood vessels, smaller alveoli. These are babies with high risk of higher PVR status. On top of this, we have seen that, preterm babies also have low endogenous nitric oxide production. In this study that compared exhaled nitric oxide in term versus healthy preterm, so not ventilated, slightly more mature preterm infants, you can see here that they have lower quantities of exhaled nitric oxide in the term group, where those featured in the white bars, versus the preterm group in the black bars. And also, there's a slightly different pattern of nitric oxide production too. You see just post-birth in the term, there's a higher exhaled nitric oxide potentially to help them with immediate postnatal adaptation. And then this declines over the first 12 hours, but increase again by 48 hours. Whereas in the preterm population, that exhaled nitric oxide quantity is low from the get-go. And it continues to show that the difference in the term versus preterm population up until 24 hours of age. On top of this, there's a separate study that also looked at tracheal aspirates of preterm babies, and you can see here that in this subset where they had prolonged rupture of membrane as well as hypoxic respiratory failure, and were introduced nitric oxide, those who were at the pre-nitric oxide phase, a lot of these preterm infants had almost no nitric oxide metabolites that were measurable on their tracheal aspirates. And Following the start of nitric oxide, you can see that this understandably increases, but also continues to remain higher after nitric oxide has been stopped. Although saying that, when they compare with the findings of the tracheal aspirates with infants who did not have hypoxic respiratory failure, it's interesting to see that even in preeclamptic, preterm babies, the amount of nitric oxide metabolites that they were able to measure was actually really very low. So this suggests that, nitric oxide on its own, or endogenous nitric oxide on its own, is not necessarily the only mediator of hypoxic respiratory failure, and there are potentially other mediators as well that can contribute to the hypoxic baby that we see at the bedside. So just setting the sort of background of, what is interesting in these preterm babies is that, there's a disruption of the natural history. These are babies who are already at risk because of just the fact that they're born preterm. There's an element of pulmonary remodeling because of the in utero conditions that they were exposed to. And then on top of that, they do have a low endogenous nitric oxide production. So, they really are quite a different population compared to the term, often meconium aspiration, asphyxiated babies that we meet at the bedside that have pulmonary hypertension. So just wanted to look a little bit about the hemodynamic profile of pulmonary hypertension. We use echo almost, at least in our unit, very frequently to diagnose pulmonary hypertension, but we know that that's not always available every single unit, and certainly not 24 hours a day. But some of the features that are used in many of the trials looking at management of pulmonary hypertension are based on some of these findings that we see on echo. So oftentimes we look at the direction of the PDA shunt. The PDA shunt itself is a shows us direct relationship between pulmonary and a systemic circulation. And with the presence of the right to left, the bidirectional PDA shunt, we can see that there is elevated PVR to SVR ratio. But keeping that in mind, the PDA may not always be present. And at the same time, in the context of a significant RV dysfunction, there may be a very low PDA shunt flow as well, that we have to take all of that into account when we're looking at kids with pulmonary hypertension. There's not a single snapshot of the PDA that makes that diagnosis. Once we have confirmed that this is a baby with pulmonary hypertension, we want to know, how bad is this? What is the estimated RV systolic pressure? And we use a tricuspid jet as to estimate this RV systolic pressure. But in the context of a preterm infant, the exact cutoff is not always well defined. And also, again, its absence does not always exclude pulmonary hypertension. As in the context of RV dysfunction, we may underestimate the RV systolic pressure as well. And how severe is pulmonary hypertension? So not just a single number that we talked about with the RVSP, but how is it in this relationship to systemic pressures? So we use a septal wall configuration, and you can see here the normal curvature, the flat septum, and the paradoxical septum, and what this means in terms of its relationship with a systemic blood pressure. But that's a subjective assessment. And then with a more objective assessment, we can also look at the eccentricity index. But again, in preterm infants and its correlation with cardiac cath, that data is not out there at the moment. And another useful tool, and actually quite simple to get, is the estimation of PVR using the PAT-RVT. PAT is the pulmonary artery acceleration time, and RVET is the right ventricular ejection time. And the relationship between the two, or the ratio between the two, as well as the individual PAAT. It helps us understand how significant the PVR is. And you can see the shorter the PAT, so the quicker it is from the to reach the peak pulmonary arterial the shorter the PAT, the higher the PVR. And also when we see that there's a notch here in the mid-systolic notch, that's another indication that there is elevated PVR in these babies. So we know that there's pulmonary hypertension. We think that it's significant, and there's therefore high RV afterload. So it's important for us to also understand what does this mean for the RV function. There are many ways that we can look at RV function. The most simplistic ways that we can look at our RV fractional area change. And we can look at this from the 4-chamber as well as the 3-chamber view, which is this view at the bottom. And it gives us an idea of how the RV is actually performing. And then as well as the tricuspid annular plain systolic excursion, the TRAPSE, which looks at the longitudinal motion of the RV to give us a sense of how the RV is doing. So in addition to systolic function, we can also look at how sort of globally the RV is performing, and we can do this by examining the systolic diastolic time, and we do this by using the Doppler of the TR jet and looking at the duration of systolic versus diastolic, and a more prolonged systolic time suggests that there is a need. There's a higher RV afterload and a global RV impairment secondary to this afterload. It's also important not to forget the LV in this context. In an infant with high RV afterload and low right-sided cardiac output, this can also lead to a lower left-sided preload as well as secondary to RV dilatation that can also impact the LV preload. On top of this, you also have the shared muscle fibers with the RV. So the LV is not a separate entity to the RV in the context of pulmonary hypertension. And then oftentimes these are babies with acidosis who have that can affect a global reduction in LV functions as well as RV function. Oh, in the absence of an echo, which, happens in many, many units, we are often left with looking at the pre and post ductal saturations. And I think it's really important to just keep in mind that, just because that there is no pre and post ductal saturation difference, doesn't necessarily rule out pulmonary hypertension. Quite often, we hear, people think, oh, this is a kid with hypoxic respiratory failure, but no pre-post difference. So we're managing them, down a different pathway. But it can happen, especially in the situation that there's no PDA. Again, less often in a preterm population, but it does occur. But at the same time, I think we talked about it before, but in a severe RV dysfunction where there's low pulmonary blood flow through that PDA, we're not going to be able to see that gradient between the pre and post ductal sats. So it's just something to always keep in mind. And when, from a clinical standpoint, that no pre-post difference doesn't mean no pulmonary hypertension. So we're going to pivot a little bit to sort of management of pulmonary hypertension. And before we go into the nitric oxide piece, I think it's important to just look at some of the sort of ventilation management and the other sort of supportive managements that we do first before we launch into nitric oxide. Oftentimes these are babies who are intubated, ventilated mechanically, and it's really important for us to keep in mind what PVR, the relationship between PVR and lung inflation is. And see here on this curve that PVR on the y-axis is at its highest when you're at residual volume, which means that you're, or as well at total lung volume. So both when your lung is not inflated at all, and then when it's overinflated. And the sweet spot really, as we all know, is at FRC. which is where you want to be able to adjust your ventilator settings to know that we're not on either end of the spectrum to worsen your PVR. And whilst I won't necessarily go into this in a huge amount of detail, and I certainly urge everybody to look at this lovely review paper from Satya and Steve. The oxygen saturations and pH is something that we are also mindful of as clinicians in these babies. And it's important that whilst we're avoiding hypoxia in these kids, that hyperoxia can also potentially be harmful as well in these babies, and the range sort of between 92 to 95, 97 is actually somewhere that we will probably want to be targeting in these babies with pulmonary hypertension. And another great review article from Amish Jain here from Toronto, who sort of has a really nice pathway looking at management of pH. I think it's also important whilst we talk about the ventilator settings, and later we'll talk a bit about nitric oxide. And with the use of echo, we can also look at cardiac dysfunction, which is quite commonly seen in pH, even in preterm infants. And it's important to also be able to support the pump aspect of things, which is your cardiac function. And here, is looking at the different types of inotropes, and in particular, also in relation to what your systemic blood pressure is doing, to help you choose the right type of inotropes or vasopressors for these babies. So in the context of RV dysfunction, you will be looking at wanting to start maybe dobutamine or epinephrine, or keep your duct open with prostaglandin. But if your function is doing well, but you're trying to reverse that balance with PVR, SVR balance, and vasopressin certainly has been shown in a number of case series as well as small cohort studies to have improved some of the oxygenation in these babies, as it doesn't affect your PVR. And then in the context of a baby who has cardiac dysfunction, mirinone is something that we can talk about a bit later on as well, that is both reduction of PVR, but importantly reduces SVR2, so with the mindful of blood pressure effects of mirinone. So as we talk a little bit more and dive a bit deeper into nitric oxide, I just wanted to introduce this as it's, a bit of a controversial topic. It appears to be that, the evidence may suggest one thing, but clinical practice is sort of not always, in line with what's out there. So I wanted to talk a little bit about the role of nitric oxide, why is there some controversies, and what are the sort of more recent articles that look at nitric oxide in this particular population. So nitric oxide, as we know, is an endogenous pulmonary vasodilator. It is synthesized from L-arginine in the pulmonary vascular endothelial cells, and then it diffuses into the smooth muscle cells, and it converts to cyclic GMP, which it activates cyclic GMP, and leading to a series of events that decrease intracellular calcium and reducing the vascular muscular tone. And it's certainly an important mediator of pulmonary vascular tone as well as pulmonary vascular remodeling. And in the context that we're talking about, the inhaled nitric oxide is great because it is a targeted administration, therefore trying to localize and minimize the side effects of vasodilatation. Now, we know in term babies that it is very much a first-line therapy for pulmonary hypertension. However, in preterm babies, why is it controversial? So certainly there's a lack of inclusion of preterm babies less than 34 weeks in a number of the PPHN trials. And on top of this, the specific diagnosis of pulmonary hypertension in this population is a bit of a challenge. We don't necessarily have set echo diagnostic criteria. And we often say that, these are infants with hypoxic respiratory failure, but what is the actual definition of hypoxic respiratory failure? And you find that in a number of studies, the definitions used are always different. So when that happens, we sort of fall to using a sort of slightly less robust surrogate for pulmonary hypertension, which is the use of nitric oxide, and that's what's often used in many of the studies to define the incidence of nitric oxide of pulmonary hypertension in preterm babies. And many of these studies also do not include echoes. So we just in general have an imperfect way of trying to identify the right babies, perhaps for the right clinical studies for PPHN. And then secondly, some of the big questions, and hopefully some more recent studies can help identify this a bit better. But does nitric oxide improve the outcomes of our preterm babies with PH? So whilst we don't have a great definition, we look at the use of nitric oxide exposure. We can see here that first study on the left in the US, there is a trend in you can see here that in two different epochs, in 2004 2010 versus 2011 2016, you can see here that in the more premature babies, the use of nitric oxide is certainly getting higher. And also here in Canada, when we looked at the rate of inhaled nitric oxide use, you can see that it is inversely related to gestation age. And then across the pond, in the UK, we see here that a third of the babies who were exposed to nitric oxide were less than 29 weeks. And then it's almost like a slight lowering in that 29 to 33 weeks, and then the further increase post 34 weeks. And you can see here also when you looked at the two different epochs that there's an overall increase in the use of nitric oxide across these two time epochs in babies who were born less than 29 weeks. So whilst the NIH does not directly tell us not to use nitric oxide and certainly advises discussion with families, you can see that there's sort of this discrepancy between what is the recommendations and what clinicians really use on a day-to-day basis. And why is that? And this study from Nick Evans and Neil Feiner proposes that potentially there are three reasons why. One being that clinicians are a lack of awareness of evidence, but potentially even more so, maybe that the evidence that's out there is not generalizable to what we have at the bedside. And that really when your back's against the wall in the NICU with a hypoxic ventilated baby, clinicians, what they want to do is just normalize physiology. So we just do what we have to and give what we have to, what we have in our pockets for these infants. And it's important also to know that, these large trials looking at nitric oxide, there's the lack of echo diagnosis makes it really difficult to really say whether there is benefit for nitric oxide or not. More recently, the AHA as well as the European guidelines have suggested that there may be some some benefits for nitric oxide, especially if there's a context of PPROM, oligohydramnios, and also if we have been able to diagnose on echo or evidence of high pulmonary vascular resistance or pulmonary hypertension on echo as well. So it's therefore a time for us to ask, fine, if we give nitric oxide, how do our babies do? Do they do better than term babies, what we know was a fairly standard practice to give nitric oxide, or is it even comparable? So in these two studies here, you see on the left that in the green are the infants who are term, and then in the purple are those who are preterm. That the babies that actually they're pretty comparable in terms of an improvement in the oxygen index in these two groups, or time to improvement of the oxygen index. And similarly, from the Japanese group here on the right, you can see here that that those who are less than 34 weeks actually do respond quite similarly. So potentially you can say that yes, nitric oxide is perhaps as efficacious in the preterm group compared to the term group. A number of small observational studies have also examined this question in terms of nitric oxide and what are the short and long-term outcomes of these babies with early pulmonary hypertension. And there is a suggestion that, these babies are actually potentially we see improvement in these babies who have been exposed to nitric oxide. And more recently, from the group in Toronto, there was a systematic review looking at those studies that I just showed you, and examining the association between positive response to nitric oxide, which is defined here as improvement in oxygenation or reduction in FiO2 within 6 hours, and its primary outcome of mortality. And you can see here that actually a positive response is associated with a reduced odds of mortality. And again, recently within the Canadian cohort, this was a prospective cohort observational study across 12 Canadian sites. And the aim of the study was to see if infants who had a positive response to inhaled nitric oxide had better outcomes than those who did not respond. And also, what is the role of nitric oxide in the slightly later period, which is not in the immediate transition period. And these infants were defined as having early pH if there was nitric oxide was started at less than 72 hours of life, and then defined as late pH if this was after 72 hours age. And the positive response was defined as having a reduction in FiO2 of 20% of 0.2 or greater within the 4 hours of starting nitric oxide. So in this study, there was echo confirmation in 72% of infants who had early pH and 63% of those who had late pH. And we can see here that the positive nitric response was more often seen in the early pH group versus the late pH group. And for the primary outcome of survival, the babies who were more mature, as well as having the greatest change in FiO2 after nitric oxide was started, as well as those who had more increased frequency of echo surveillance and was associated with an increased survival. Whereas those in the late pH group, the only identifiable factors that were associated with an improvement in mortality was actually the pre-nitric oxide illness severity markers, which were lower FiO2 as well as pH. So therefore, drawing the conclusion that potentially nitric oxide in the right patient, and in this case would be preterm babies who have pulmonary hypertension during the transition period in the first 72 hours of age, may benefit more than those who are exposed to nitric oxide for more of a late acute pH. And so I just want to finish up a little bit as we talk a bit about second line therapy. So we are quite fortunate in Canada that nitric oxide is pretty easily accessible. But we know it's expensive. We know that this is not necessarily the case in all settings across in the NICUs across the world. Although oftentimes, a lot of the studies are not necessarily in the preterm population, but I will draw your attention to a couple that are. Just looking at the different pathways of vasodilatation and vasoconstriction in the pulmonary vasculature. There is three specific target pathways: nitric oxide that we've talked about, and there's also the endothelial pathway as well as the prostaglandin pathway. Often, the most commonly sort of alternatives that have been used either concomitantly with nitric oxide or sildenafil, as well as milrinone, which is on this pathway. And those are really the two studies that I could easily find that were that were actually examined specifically in the preterm population. And I'll just and show you these couple of studies that is out there. So this was a pretty recent study from Germany where they looked at IV sildenafil in the preterm babies for early PH. And this was a retrospective cohort study of 58 infants, of which 95% were already receiving nitric oxide at the time of introduction of IV sildenafil. And you can see here that that within 12 hours, that the oxygen index of these babies have dropped quite significantly in those who responded. So thereby, similarly to INO, those who responded did well, and also improved survival in those who have responded compared to those who did not respond to sildenafil. And in this terms of milrinone, which we touched about previously with more of an inotropic use, we know that also can reduce PVR as well using the prostaglandin pathway. Here in a case series in preterm babies with pulmonary hypertension and RV dysfunction, you can see that babies who have started milrinone, the overall ventilation oxygenation burden has reduced within 72 hours of starting milrinone, and on echo as well. Those who were started milrinone, you can see that improvement in their left as well as right ventricular function, and also the cardiac output too. Whilst we don't have really many other studies looking, especially at the preterm population, this is a study that looked at bosentan, which is another drug that can be used in pulmonary hypertension in older children. This was a single center open label RCT that compared sildenafil versus bosentan in near-term babies. And you can see here that sildenafil had a quicker reduction in pulmonary arterial systolic pressure, and also there was a need for fewer adjunct therapies in the sildenafil group compared to the bosentan group. So just want to kind of put this all together and hope that from what we've discussed today, you can see why the preterm population is a bit more unique compared to the term population when we think about the underlying pathophysiology for PH. And the diagnosis of PH using echo is important because we ultimately will need to know that if we're treating with nitrate, that we're facing a baby with a high PVR, because that is what nitric oxide is used for, is for reduction in PVR. And actually, we've seen in the more recent study in JAMA that babies who've had more follow-up echoes, this was associated with a better outcome. And ultimately, I think there is benefit, I believe, in managing babies with early PH with nitric oxide. And I think there's still a lot of work that will need to be done in terms of other adjunct therapies. And I guess we'll have to wait and see. And it was difficult in the preterm population for sure, but to see what else may come in terms of other medications that can be used in this population. So thank you very much.
Okay. Thank you very much.
Thank you, Faith, for that talk. That was a really great overview. And so we'll open up the panel and see if for any comments, and we do have some questions that are in there. But any comments, initial comments for Faith or the talk? And nice to see you all on here.
I just want to say how wonderful a presentation it was, Faith. Well done. Really enjoyed it.
Thank you very much.
So, Faith, maybe I'll start you off with a question. This is a question on that, actually a group of people here that we were kind of talking through, and one that's on the Q&A. When thinking about preemies, are there different dosing regimens that you're using for INO and also weaning considerations for this patient population? So are you starting at different dosing? Is this something that, you have your echo, you have this kid's that's clinically seeming like they have PH, you put them on. What do you start at and how do you decrease?
So certainly in the literature, you see people starting sometimes as low as 5 parts per million, increasing up to 20. In our center, we haven't necessarily adjusted our guidelines specifically to preterms, and we often start at 20 or 10. But understandably that, these are small infants who may have a different response to inhaled nitric oxide, and often the case of trying to reduce their exposure to toxins or drugs, it's certainly reasonable and be interesting to hear the panel in terms of what their usage is as well of inhaled nitric oxide in this population. So yeah, I think often in our practice, 10 or 20, but I have certainly seen in the literatures even starting from as low as 5.
And how about everyone else on the panel? What are you all starting with for your preemie kids?
Well, I will tell you in practice, I think most of us are probably starting with 20. I have been encouraging people to try to start with 10 to see where they get rather than jumping right to 20. But I think that kind of change is going to take some time and probably some evidence to make people feel more comfortable with that. I think we're just so comfortable with just starting at 20 that that's just what people are used to and that's what they do.
Can I say in the term baby, of course, we had the history of the 20 ppm story, and that began with the sheep models and things like that, and never saw, because remember in the old days when they started out, it was 80 parts per million in some settings. So we've come a long way. So 20 was good for the term baby, but I really share everyone's concern. I know the whole panel feels this way, that we don't want to give too much too quickly. We don't have abrupt change in systemic and pulmonary hemodynamics and the sequelae if there were to be a big response. And I think time's on your side in terms of there's not a sense of urgency perhaps to immediately escalate that quickly. And I also a study way back when of preterms with hypoxemic respiratory failure before the use of targeted neoecho. But in that subgroup, a very small study published in The Lancet showed we used 5 ppm. And we almost saw a death signal improvement with 5 ppm alone. We certainly saw remarkable improvements in oxygenation. We did not see additional IVH, at least grade 3, grade 4. And so 5 ppm may be sufficient. And so I would, safely worry, watch, but maybe starting with the lower doses, but there's very little data on that. But the final thing I want to say is, what do y'all think about how you withdraw nitric when you think there isn't a response? And to me, again, the whole thing of rebound can be so startling sometimes. And I think one of the early trials where they gave low dose nitric, again, before using echoes, pH wasn't the target. There was one study, the NIH study, where they rapidly withdrew nitric. And that was the only study I know where they saw a significant increase in advanced hemorrhage, IVH. And I think a lot of it may have been quick on, quick off. And again, the risk of that abrupt changes, not just with the lung circulation, but as Patrick and many others on this panel have taught me, it's the interface with what's going on systemically. And so to me, it's that lower dose, being patient, observant, do your serial assessments, and moving forward from there, to me, is, I guess, how we would think about it.
Can I piggyback on something? Neil, do you have a comment on that before I piggyback question?
No, after you, Shazia. That's great. I'm really enjoying the discussion.
I'll pose this to you actually. This concept of what Steve was talking about and having some caution with coming off rapidly, but in the cases of patients where they have a PDA, or if there's concern for potential pulmonary hemorrhage in this patient population, or are there other contraindicators? What do you think about those patients where you have a PDA that maybe has some, you have evidence of PH, but then how do you titrate with those kind of?
I think that's such a great question and consideration, and it's this. I think we're really still in this phase of understanding not just the different phenotypes that are responsible for pulmonary hypertension in both preterm and term states during the transition, but also the dynamic nature of those, and how what may appear to be a phenotype that is a pulmonary hypertension state, which it's appropriate to think about dropping PVR if we think there's a significant pulmonary arterial precapillary component to that, can quickly transition to one where, as PVR declines, we're going to see more left to right shunting through a persistent ductus. And then, exactly as you say, the risk is pulmonary overcirculation, high left ventricular output, and the impact of that on the lungs, absolutely, in terms of pulmonary hemorrhage, but also on the cerebral blood flow as well, and probably goes to exactly what Steve was alluding to, that risk of IVH. And I think we're still phenotyping those different mechanisms of pulmonary hypertension and that dynamic transition as well. And I think many people on this webinar have shared apocryphal cases of babies where we're delighted to see a response to pulmonary hypertension, but then if we're not keeping a really close eye and predicting that change in pathophysiology, the patient has then suffered, unfortunately, the pulmonary hemorrhage and or IVH. I think the other component of that, of course, is that we're starting to understand the role of left ventricular dysfunction in these babies as well, both to their pulmonary hypertension physiology and to that pulmonary hemorrhage physiology as well, in terms of increased pulmonary venous pressure. So, yes, still unraveling that one, I think, but we need to be cautious, don't we? We need to watch these babies and not congratulate ourselves too quickly that we've treated the initial phenotype without anticipating what they're going to transition to next.
Yeah, I think, Neil, that really highlights the need for sort of really close surveillance because of the evolving picture that is so quick and so vulnerable that these patients are, and the sort of serial assessments really. And pulling the nitric off, sometimes you will then go backwards, and then what do we do with that is also another piece. Do we start where we are, start at the lowest dose, and then how long do we leave that on for? That certainly is such a and really hard to have studies for this as well to be able to answer definitively those questions.
If you have a preemie that you've put nitric on and you have a PDA in there, are there clinical ways for those that may not be able to get echoes as frequently? Are there other clinical manifestations that we can look at to be able to help to address whether to take off the nitric, is the shunt changing? Is there some assessments we can use from a clinical standpoint and not have to get to echo?
I mean, I think from sort of, this is perhaps more sort of anecdotal or personal practice. I think looking at their blood pressures, in terms of especially their diastolic pressures, if they're oxygenating better, and you see that diastolic pressure or the is starting to dip, then for me, that may be an indication that I want to at least scan early if I have the ability to scan, or if not, then I'm going to start thinking that the shunt is reversing. because in the presence of bidirectional or right to left shunt, you're not going to have a improved oxygenation. So certainly you see the FiO2 coming down, you see that diastolic coming down as well. That for me is a bedside clue potentially. It's my personal practice.
There's been a couple mentions in the chat box of kind of ancillary therapies for pulmonary hypertension. Obviously, we're focused pretty extensively on the pulmonary vasodilators, but kind of thoughts on how do we fit in the role of medications like diuretics, sedation, things like that. If anybody can take that question.
Sure. So in terms of, yes, there's certainly merits in things like sedation for sure. But of course, if we're talking about the preterm population too, sedation in this population comes with its own drawbacks, and how much you sedate a baby too is you want to be able to hopefully allow them some drive if they can to be able to breathe. But of course, that balance between completely taking that out and doing all the work for them, you know, it comes with its pros and cons as well. In terms of diuretics, it's not something. I think it all really comes down to what are you treating? Is this a PVR problem? In which case, then yes, nitric is what, or a vasodilator is what you're going to be looking for. Or if this is a problem with pulmonary vein stenosis, which is rare, then you're going to have to look at a different tack. And nitric is certainly not the therapy for this group. So, as much as we're discussing just nitric, the real key thing is, I think, knowing what your problem is and then knowing where you want to go and then figuring out the steps in between to get to where you want to be.
I have two things sort of add in there. I think a really important part of this is choosing your inotrope suppressors appropriately in these kids. And I think that sometimes that is overlooked in treating this population because there isn't a ton of data about a lot of meds that we use in this patient population, but that's a really key issue. And then also, as far as the diuretics go, I just want to make sure that, diuretics is one of the first line treatments that we use for BPD related pulmonary hypertension later in this population, but it's not something that I would use in an acute setting for pulmonary arterial hypertension. If it's, a flow mediated pulmonary hypertension or something else, and then there are some arguments to be made. But for true pulmonary arterial hypertension, that would not be a choice that I would make.
This is a question that I think we often get, and it's trying to balance the clinical presentation of the baby with the echocardiographic interpretation, as in, when are you treating an echo as opposed to the baby? If you have a baby on a moderate amount of oxygen but severe pulmonary hypertension, is that significant? Does that need treatment? And kind of vice versa. What if the oxygenation is high but the pulmonary hypertension is mild? How aggressive do you need to be when treating the clinical kind of hypoxia and respiratory failure versus the echo findings? It's a very hard question. I'm just curious kind of what the panelists think on this.
A great question. And I think everybody's always have met, with the same circumstance. For me, I like to not just treat echo. I think the baby is still, what's in front of us. Potentially, echo may give you a clue that what's causing the hypoxic respiratory failure, but it may not. And then that's, I think, when we're going to have to start looking at the parenchymal lung disease. Maybe you're underinflating, the whole lot of other things that we also haven't talked about today, but it's super important as well, in this population. So I think echo is a wonderful tool, but it is certainly, I look at it as an adjunct to what is in front of me, which is the baby.
I'm going to jump in one more time. You guys can tell me to stop if you need to. In some of these kids, I think it's really important to remember that, especially in preemies, You know, half systemic right-sided pressures are not going to cause this baby to desat and desat in 100% oxygen. You know, that would really make me think, what am I missing? And is there something else going on here? Because normally a kid who has who's desatting significantly and in a ton of oxygen is going to have pretty high right-sided pressures or evidence of that on the echo. And vice versa, you know, if you see not that bad pulmonary hypertension on your echo, no, other way around. If you have a good looking kid who's not in a ton of oxygen, who then has evidence of severe pulmonary hypertension, that would also make me think, what am I missing? Is there a shunt somewhere that I'm missing? Is this like a version of high output heart failure that I'm missing? Does this kid have a vein of Galen malformation or some other shunt somewhere that I'm missing? And so in those situations, I would really think, you know, maybe it could 100% be pulmonary hypertension, but is there something else that I haven't thought of yet that we need to treat differently?
I think this is my last question. I'm just curious to ask, take the chance to ask Dr. Abman, your thoughts on these babies that have acute pulmonary hypertension. You know, maybe it's only for 72 hours. Do you think does this represent a you know, kind of a potential lifelong contribution to their vascular disease, or is this true a one-off thing that they're going to grow out of and be totally fine?
Yeah, no, this is a great question. And so that's where the early echo changes that are seen co-travel with late outcomes, which is pretty startling. I mean, that day 7 echo, even in stable preterm babies, showing subtle signs of, by echo, of some increase in pressure, which we label as early pulmonary vascular disease. They still, and it's being a biomarker for severity of PPD at 36 weeks, the presence of pH at 36 weeks, but surprisingly, respiratory outcomes of the first 2 years of life. And it's so startling there. The other side of the early echo changes, of course, are beautiful work from a number of different centers where they've looked at mortality with severity. And so some must be aggressively treated early on because it co-travels, and how to discern the differences is really what we're talking about here, what really needs to be managed with an integrative physiologic approach, which you've all beautifully mentioned already. And I think the highly dynamic nature of change. So you can't get one echo, we're done, see you, but rather what you already learned from targeted neo-echo and integrating that with ventilator care, changing respiratory support is vital, systemic hemodynamics, all these things we've talked about. And so it's really a dynamic window. And if you look at the work from Groningen, you know, Sanai Arons was the lead author on a beautiful paper where, you know, we early on looked at echoes, is it there or not? You know, like it's a binary thing at day 7. They looked at early changes that had at least 3 different phenotypes within that early period. Some of the classic PPHN physiologic markers as we see in the term baby, which you nicely described, Faith, already, those kinds of kids who are sick, and really we think we could make a difference how to tackle that. The others, it was really more flow related, where the avoidance of nitric, of course, has been raised and potential risks. And then a third category that really had neither, but just estimates. Pressures were high, but they didn't see right to left predominant or marked flows. And so they had 3 different categories. What's so intriguing about it is all 3 of those groups we're at risk for later morbidities, later outcome issues. So why is that? So part of it's something that physiologically is causing real disease you've got to tackle. Sometimes it's severe, profound, life-threatening, you got to get on top of it. Others, it's maybe a co-traveler of a marker of stuff that's going poorly with the transition more globally. And so really what to think about has to be put in the context of what you're talking about already. What's the context of the baby? And so I think to me, these make the big differences. But I think as a marker of poor outcomes, a lot of work from Korea has been beautifully done. Same kind of conclusion. Something's going on. This is a marker of delayed transition of risks. And we may see later on that underdevelopment of the lung vasculature does indeed play a role in chronic, not just pulmonary vascular sequelae later, but also alveolar growth abnormalities, other things with how the parenchymal lung grows itself may co-travel. And I go on about some recent work with DLCOs for surface area in preterm infants, even without severe PPHN. that DLCO is low in a significant proportion, stays low through infancy. And then when you look at them as adolescents, the DLCO tracks with PA pressure by echo. And so there is something going on there, not just the airways, we worry about COPD, and late sequelae, but the vasculature itself, the parenchyma itself, the emphysema risk itself, there's something going on with the vasculature as well. So that's a different context from acute pulmonary hypertension, but it does mean that let's think about what is going on with those babies. If they still have some element of pH by echo, it's especially important to follow up on that, especially as they graduate from the NICU and during infancy and follow-up, because I think we worry about what happens with secondary hits, intermittent hypoxia, viral infections, other things that may happen. So it's nice to know, do they really have any persistent and late pH sequelae once they get through the acute crisis itself? So don't forget the follow-up stuff, and I'm sorry to ramble so much, but these are, to me, they're very exciting questions.
Thank you, Steve. Patrick, you have a comment or question?
Yeah. Hi, guys. Sorry, Faith, wonderful talk. I watched you and listened to you while walking back to my hotel here in Boston. I'm a student here for the past 2 weeks. I have a comment first, and I have a question really for all of the audience. And just reflecting back on that really important question about how do you monitor babies, particularly babies who respond to nitric oxide in terms of adjusting weaning and stuff like that. And just a reminder to people of the importance of the preductal systolic blood pressure, which is probably most reflective of your cardiac output as a potential clue. But the other thing that we've talked a lot about, and I'm sure Jack can attest to this as well, it's not something that we do, but is there a role for non-invasive cardiac output monitoring? And actually dynamically seeing those changes in cardiac output certainly would give you a lot of reassurance that if the cardiac output is rising significantly, that potentially would prompt you then to drop the nitric oxide. So again, I don't know that anybody has studied it in this setting. I know Daniel Rios' K, non-invasive nitric oxide or non-invasive cardiac output monitoring was part of her kind of multi-parametric kind of tool set. And if there is a significant number of pulmonary hypertension babies, that might be something we could learn from. But anyway, here's the question. I want to talk about milrinone. Okay, so milrinone is a drug that we do not have a randomized controlled trial in preterm babies. We're currently doing one after PDA closure. There's not a lot of literature outside of Nick Evans or Martin Kluckau's kind of low SVC flow study, which was kind of a negative trial with potentially kind of poor response in some babies. And then we have the animal literature that Steve can maybe talk about, the fetal ovine model, suggesting that maybe a negative inotrope. So, we use milrinone, we use it in pulmonary hypertension, but how do we guide people in better using milrinone? Because it is a drug I hear horror stories about oftentimes. So maybe you can start, Faith, just in terms of your practices in Toronto, kind of, do you use milrinone in the first 24 hours? Who do you use it on? How do you guide practice and so forth?
It's a great question, Patrick. I think, like I said, the jury's out in terms of, evidence. We don't have a lot. We know in theory it should work, and we have seen in practice that it can work. Certainly in the preterm population, I think a number of factors to consider is, things like drug accumulation and clearance. So if there's a kid we know with renal dysfunction or potentially multiple sort of renotoxic drugs, we may want to consider not loading those kids or just starting them at a lower dose, and for us is 0.33 mics per kilo per minute. And oftentimes in the prem population, we don't often give a load, and we just start as an infusion, then with subsequent monitoring and then increasing if we think it hasn't made an effect or not. But it is definitely a tricky drug, especially when it comes to the systemic side effects that we're all very wary of with hypertension. And sometimes it may also involve starting vasopressin on top to balance out that at lower SVR with the side effect of milrinone to be able to sort of resume or sort of get your physiological, to get you back to where you're supposed to be physiologically. So yeah, tricky one for sure, and used with a lot of caution and sometimes a little bit of trepidation.
Do you want to comment on systolic versus diastolic blood pressure in terms of that decision making? It is, I hear a lot babies who are already very hypotensive getting milrinone. So is all components of low blood pressure a contraindication, or does it depend on whether it's systolic or diastolic?
So me, sorry.
Yeah, you.
Yeah, so certainly when we're looking at milrinone and sort of the vasodilatory effects of milrinone, we will be paying attention in particular to the diastolic blood pressure. However, and that's where sort of the vasopressor use of vasopressin may be helpful in that sort of countering of that effect. But if we're seeing that the lower systolic blood pressure is actually as a result of low cardiac output state, which is what we can come see, maybe it's not necessarily vasopressin or maybe even milrinone that's what we need in this state. So it really totally depends on the physiology.
Thank you. I agree with you. I just want to hear from Neil and Shazia and Stephanie. Are people using milrinone in the first 24 hours in your centers?
Yeah, maybe I can come in first if you like, guys. So the answer is yes. I suppose the majority of our experience has been for a long time in the term population. To the last point about where have we gained confidence in using it safely without seeing a side effect profile, my own practice is not to use a loading dose, to start at the low dose once the patient has achieved normotension, and if necessary, that's using either a combination of inotropy or mild vasoconstriction, depending on, as you said, Patrick, the kind of hypotension phenotype. Is this a low cardiac output situation or is it a low SVR situation? To be honest, there's not many low SVR situations where we would actively want to use milrinone, perhaps with the exception of unbalanced circulations in the setting of congenital heart disease, where we're actively promoting flow, or for example, severe vein of Galen malformation or something like that, where you're trying to medically manage the balance of systemic flow versus ABM flow. So translating that experience of milrinone predominantly in the pulmonary hypertension population in the term ABs into preterm, I'd say that we're gaining experience. We're cautious with milrinone to the same degree. We avoid loading dose, we escalate dose slowly, and we wouldn't start it in a setting of a low SVR state. In a broader context, I suppose the introduction of any new medication, particularly into the preterm population, always generates some resistance, and probably that's important resistance from colleagues. And I think a challenge for all of us is how do we take our colleagues along with us, not just in terms of use of these specific medications, but more broadly in a hemodynamic approach to management of these patients. Because not to speak too sweepingly, but I think there's a long history of respiratory management of the preterm population in neonates, and centered on that an ethos that a patient with impaired oxygenation or impaired gas exchange has a parenchymal lung problem that we can ventilate them out of. And I think there's a broader story here about how we share all the discussion and all the thinking that we've got here today with our teams and with our colleagues to help them understand the real hemodynamic centric aspects of managing these patients. So sorry, I've gone a bit off topic there, but I think it reflects the fact that if we have as a group some uncertainty about management of these medications, you can guarantee that our colleagues do as well, and will question us on it.
And then I would say we have not used it as much in the preterm population. I think for our term population, we have used it some. I think the concept of using it with vasopressin, if we do have some vasodilator, I think I'm curious about milrinone in those preterm patients that may have some diastolic dysfunction, and whether that in combination when using the nitric or waiting a bit on the milrinone and then using some nitric, if that is a strategy that might be helpful, knowing that if that's the case and you have a PDA in place, then as that milrinone's on board and you have some vasodilatory effect, you're going to be able to differentiate well between a PDA that's starting to go left to right, and the milrinone contributing to that. So I think that is a little question for me, just to think about separating systolic and diastolic blood pressures with milrinone, INO, and a PDA. I think that would be a little bit of a challenge.
We will use milrinone in preemies, but very judiciously. I will tell you, we don't load anyone of any gestational age. So we would just start normally at a low dose of 0.25, 0.3, 0.5, something like that, and go from there. In this particular population, especially in the first 24 hours, where you're not likely to have a ton of urine output unless you have, an extreme preemie that's more likely to pee out in a shorter period of time. I also think a lot of my colleagues would hesitate to use vasopressin this early as well, when you're really concerned about urine output. Whether that is, evidence-based or not, I've seen the hesitation. But I'm a huge fan of starting milrinone with something else. And so I will often not start milrinone by itself. I'll start milrinone and epi, or milrinone and norepi, or milrinone and vasopressin at the same time. And then I can always come down on whichever pressor I have chosen if the blood pressures go up. But I tend to take our CTICU approach and just start milrinone with something else.
Thanks, everybody.
Can I ask back to another question that's actually come up a couple of times in the chat about, we touched on it, but is there a contraindication you all have for IVH and using INO? Is that a contraindication for if you have a baby that's got grade 2, or if you have one grade 3 and 4, would that preclude INO use early on in that patient?
Certainly in our center, not necessarily, no. Well, I think the pathophysiology of IVH is really multifactorial, and I don't think you can necessarily say that nitric oxide is the sole cause of, of IVH in this kid, either before you start or after you started. And, you have a very sick kid who's hypoxic, low cerebral blood flow, all of that can all be significant contributors to IVH. So no, not in our center. We certainly tried in terms of management of IVH, or hopefully in terms of preventing IVH. It's sort of more of the multiple assessments, not, shooting sort of your blood pressures way up with, lots of high doses of drugs, or at the same time, trying to avoid, large swings in your saturations and pH, and we sort of manage it in that way.
Yeah, can I say I really support that approach as well? And I go back to the old days when we first started studying fetal sheep. When we measured cerebral blood flow giving nitric, we saw no changes in cerebral blood flow, no changes. And so that gave us the encouragement to move forward clinically, of course. The second thing is the preemie trial that I mentioned, where we came close to showing a survival signal. I have PTSD over that study because we came so close. But the part that was so striking was that there was a remarkable reduction in grade 3-4 IVH, remarkable reduction. And because we were using low dose as part of it, and it was so strong that working with pharma in that era, we even considered with the next trials, using that as our primary endpoint, was the reduction of severe IVH because of that safety profile. And it gets complicated to sort of put it up and down, because up and down with the hemodynamics, because so many things are going on dynamically. And that's where I think the idea of going slowly with lower doses initially, being cautious, doing the serial reassessments at the bedside, as you've learned to do with echo and what you're doing with the ventilator and systemic hemodynamics, all those things are fantastic. And I don't think nitric oxide itself, without perturbing or giving to the wrong baby, will worsen things. So being cautious, integrating the physiology that way. Because the other signal, of course, was NO. In the old days, we thought it would block platelet aggregation. And that was why we were so worried about IVH being such a risk. and yet it just didn't play out. And frankly, the effect on platelets over time, we just haven't consistently seen that from clinical or laboratory-based sciences. So anyway, so this is my bias, but lower doses, being cautious, being thoughtful, and balancing it off and looking for changes over time with whatever you do, I think are critical. So thanks. Yeah.
And can I add, if you, so this sort of speaks to a point that Steve had made earlier on for longer term for this patient population. What would you all do with a PDA on a patient that had acute PH initially, you had nitric on, still has a PDA present? Do you worry about taking that off as a pop-off for that patient population? Do you just say, go ahead and say, well, this is now a left to right shunt and that flow in that vascular bed is probably not going to be helpful. Let's close it off sooner. What's your approach for the PDA in this patient population? Recognizing we don't have a lot of evidence just yet.
I'm going to steal an approach that my colleague Anne-Marie Hukin used very recently when she was talking about this, which is the PDA can be friend or foe. And I think or it may just be innocent bystander, I suppose, as well. And it's for us, I suppose, it's figuring out at that point in time, in the context of that clinical situation, which of those is it? For example, we see occasionally these babies who have what's almost like a functional pulmonary atresia with just such gross RV dysfunction that RV output is negligible, and it's the pulmonary circulation seems to be dependent on that left to right shunt even very early on. They can then transition as the PVR drops, RV function improves to a significant left to right shunt causing pulmonary overcirculation. And so suddenly it's gone from friend to foe. And yeah, in that situation, you may actively be thinking about strategies to minimize the left to right shunt through the duct, whether medically or even interventionally. So I think it's about understanding what your relationship with the duct is at any point in time, and how much you want to stay in a relationship with it. Yeah.
Okay, well, thanks everybody. I think we ran a little bit over. I apologize. There's a lot of questions. This was fantastic, fantastic discussion. So I think we can all agree that Faith gave an absolutely amazing talk. But also thank you to our panelists for very thought-provoking discussion. And we'll do our best to the questions that are remaining that have been answered. We'll do our best to answer kind of going forward. But thank you everybody for joining. Have a great rest of the day.
Thank you.
Thank you.
Okay, thanks everybody. It was great seeing y'all. So, and Faith, again, beautiful job. Really nice.
Thank you very much.
Okay. All right.
Yes.
Hope
Well
to see
done,
you.
Faith. Thank you.
That was a fantastic talk, Faith.
Right.
Hard subject, my goodness.
Okay, see y'all.
Thank you so
See ya,
much.
bye-bye.
Bye, guys. Bye, guys.
Bye.
Bye.
Great to see you all.